There we go. Well, welcome everybody. So glad to have you guys with us today. So we are Eosinophilic and Rare Disease Cooperative, ERDC. It's quite a mouthful, I know. And we're the people who bring you the heat kits, which is how we met many of you through sending you a heat kit. And our organization is really focused on helping people have increased and improved access to quality care for their rare disease, as well as access to their medications and treatments. So we don't duplicate what's already out there. There's some amazing organizations out there who have great information about sort of the disease state and do educational live streams about the disease itself. And we leave that to them, and we focus on, the medications, the treatments, and the way to get improved care, like through the heat kits. So we've got so much to cover today, so I'm not going to take a whole lot of time. But let's see. I don't know, Rebecca, if we have any of the polls that can go yet, and if not, that's okay.
Give me a couple minutes and we'll have that ready to
No,
go.
no problem. It's no problem. So here's what I would say. You've been putting where you're from in the chat, which is great. Now I'd like you to put in the chat how many medications you're on. So yeah, I saw oh my goodness, in your face, Marlene. And yes, it is so many. So just go ahead and put that in there. And the reason that we're putting that in there is it's a reality check that we all have every single day. We have a love-hate relationship with our medications. But we know that they have a unique role in, managing our disease and stopping inflammation, preventing damage, treating the damage that we have, and improving our quality of life. And if we can understand what these different medications are and how they work together, then we can kind of hear it as an orchestra as opposed to a bunch of instruments that feel like they're screaming in our ear all the time. So that is really the goal of our live stream today, is to help you understand a little bit more about the purpose of the different medications, how they work together for you in our complex diseases, and also how the partnership works. So, we know that we have to have knowledgeable and curious specialists, including our PCP, who treat us. We know that we have to be able to be open and honest with our providers in order for them to treat us well. We are so fortunate, many of us are so fortunate to have amazing support systems and loved ones and care partners. And, they watch out for things that are happening. We've got pharmacists, we have insurance companies, and we have pharmaceutical companies who actually make these medications. So it really is a whole group of people that are collectively working together to make this happen for us. So today we're going to focus on medications for MPA and GPA because there's so many different medications for each different disease. But we're going to focus on those. If you have a different disease and you're on, before you go hopping off, I can tell you that we share a lot of medications in common. So there will be a lot of information that I think will apply across different disease states. So I also want to say a big thank you to Amgen for their support in making this happen, and their support in making the heat kits available. Those of us with a rare disease know that, medications, they're not a nicety. They're not just something that's, oh, that's nice. They frankly are, for many of us, keeping us alive. So I, for one, am super grateful for our partners like Amgen, who help make these medications available so that we can actually live longer and better with our diseases. So, all right, enough about that. That's just sort of an overview of what we're here for today. I am really excited to introduce our colleagues who are making this happen with us. And you guys can wave maybe when I call your name. So Pam Squires, and she does all of our program development, and she is the one that puts together all your heat kits and blesses them before she puts them in the mail, quite literally. And she also is a spouse and care partner of a person with EGPA, which is me. And so she is going to be here kind of keeping track of what's going on and thinking about ways that we can bring other educational pieces to you. John Stadler is going to be helping out today. John has a beautiful background of fall trees. And John is one of our great board members, and he is going to be tracking your questions and comments. So you can feel free throughout. You don't have to hold on to them. Just put them in the chat as they come to you, and John will track those, and then he can ask those at the end. If you have a question that you think, I don't really want to put this in the chat, but I do want to know about it, you can send him a private chat as well. So, and he will get that and he'll pull all that together for us. Rebecca Cordiner is with us today, and she is our tech genius and website genius, and she just created our new website. So if you haven't had a chance to check that out, it is EOS. Well, you know what? You can just do heatkit.org and you will get to our website. So that's even easier than worrying about eosinophil. And then super excited to introduce you to Dana Saffold. So, gosh, Dana, I feel like I've known you now for quite a few years. Dana is a board certified geriatric pharmacist and fellow of the American Society of Consultant Pharmacists. She has served as a representative on the ASCP Board of Directors and is past president of the Georgia chapter and the Florida chapter of ASCP. She's an advocate for patients and a frequent guest and lecturer at state and national conferences, addressing topics from disease management to business, operational health issues for service providers. And I can tell you from my personal experience with Dana, not only is she incredibly compassionate, she is wicked smart. I don't have much of a science cell in my body. And so I am so incredibly appreciative of you sharing your knowledge and your expertise with us today. And so how about if we all do a big wave? If you want to turn on your camera, we'd love to see you, but a big wave to Dana.
I'll wave back.
Thank you. All right, and I am going to get us started because like I said, we have a lot to do. Okay, let's see. Let me get into my screen. All right, and then there we go. All right, so we're going to talk about polypharmacy, why so many meds. And I kind of covered this a little bit. Our goals today, though, are really for you to get a sense of what meds you're on and how they fit in that overall picture, back to that orchestra kind of concept. How do they make your orchestra as opposed to just a bunch of out of tune instruments? We also really hope that you leave today having some confidence so that you can have a richer conversation with your healthcare provider. We know that you can talk with your healthcare provider, but so much of what they say can go right over our heads, and it's overwhelming with the doctor, when you're sitting in the doctor's office. So the more you understand about the medications you're on and the role they play, the more you're likely to be able to have an educated conversation with your doctor. And we hope that you find that happens today. And we also want you to understand the pharmacist's role. I think that's probably a role that many of us don't utilize to its fullest. And knowing you're not alone in this polypharmacy reality. So what this is not is you are not leaving today and going to be a chemist or a pharmacist. So Dana's going to go through a whole bunch of information and use it with soft vision. So take in what works for you, and also know you don't have to scramble for notes. We will be sending to you and everybody that registered a document that has all this information on it. So you don't need to worry about that. And this will be available to watch later if you want to watch it later. All right. So Dana, let's get started. What is polypharmacy and why should we care?
Well, I'm sure many of you have already experienced that some of the medications you're taking makes you feel worse than before you started taking medications. And polypharmacy is a term that is used when people take 5 or more medications, which is actually most of us if you count your nutritional supplements that you may take. And when you take 5 or more medications, that's been the official definition, but anybody that takes 1 or 2 medications has a risk for an adverse effect or a drug interaction. Polypharmacy is a term that was coined by the physician organizations, and it came with a negative connotation. In other words, if you have somebody on polypharmacy, it's somebody's fault. Either the pharmacist wasn't paying attention, or you see multiple doctors, or maybe it's your fault because you take so many medications. And I always put a stop to it right there. If you have polydisease, if you have hypertension and you have your rare disease and you have adverse effects from the medications you take from the rare disease that you cannot stop, if you have multiple needs, then you may need every single medication you take. I think polypharmacy is a pejorative word that we should not just automatically use. And as we noticed in the chat, we have people on 1 medication, we have people on 6 medications, we have people on 26 medications. And I would venture to say that for you, the medications that you are on may be exactly the right thing for you now. At a time in the future, your medications may need to change. So rather than polypharmacy, we need to understand why we are taking each medication, what it does in our bodies, and what potential adverse effects we could expect. And then we can make that choice with our physicians. Is that adverse effect acceptable because of the benefit that we get from the medication? So does the benefit outweigh the risk? If it is an acceptable risk, what do we do to treat that adverse effect so that we don't feel so bad? And that is, to me, it's the science of pharmacy. So polypharmacy isn't a bad term. It is frustrating. We have to plan our trips. We have to carry extra bags with all of our medications in it. I'm sure most of you have some type of a medication monitoring system where you set your meds up so you can track if you've taken everything every day at the appropriate time. And if you don't, then I'm happy to tell you a lot of different options that you have for that. But yeah, just because you're on a lot of meds doesn't make it bad. It may be the perfect thing for you, but the more medications you take, the greater the risk you'll have adverse effects. And I've seen in the chats already today, some people have fatigue, some people have dizziness, some people feel depressed, and all of that can be either a part of your disease, or it could be a part of the medications, or most likely it's a combination of both.
Thank you. That is wonderful. Actually, that really helps. I didn't realize where the term came from, but yeah, that's fantastic. And just, just to kind of make sure that we all have some of the same key terms before we get started, because when you dive in, we're gonna talk about these. What is an indication?
Oh, what is an indication for me? So
Yeah.
the indication is the purpose of the drug. So the indication generally will refer to the overall action that that drug is supposed to correct.
Okay.
So if it's an antihypertensive, then it controls blood pressure and so on and so forth. A chemotherapy drug will treat cancer, but then within that, there will be many medication classes. And these type medication class attempts to collect similar medications that work through a similar pathway. So I have a major indication of a chemotherapy agent, and then we will have maybe 7 or 8 different classes. of how each one works differently.
Okay, perfect. And then, you know, there's names, there's a trade name, and I don't, chemical or like the generic name. And I don't know that people know if they're
So-
the exact same.
And yes, so in the material that we put together for this slide deck and in the handout that you're going to send out to everyone, we've listed the medications by the generic name, but then we've also listed the brand name if it is available as a brand name. Prednisone has been generic for 50 years, so it's just available by the generic name. But some medications are like that, where the brand name is not even manufactured by the original manufacturer anymore. It's just available as generic, and others have multiple different brands of the same chemical.
Perfect. Okay, thank you. And then the last one is off-label. There's on-label and off-label, and you'll see that in the stuff today. Just to kind of mention what off-label means.
Okay, so don't get worried about using a drug off-label when you have a rare disease. On-label means that the FDA has approved that product. They have found it to be safe and effective for that indication. Many brand name drugs that have come on the market in the last few years will have a specific indication that's in their label. And by label, I mean the package insert that the FDA approves when they approve that product. But older products that have been around for many years, either because there's just a few years left on their patent or because it's already available generically, then there is no pharmaceutical company that's going to invest in the clinical trials and then submit to the FDA to get a FDA approved indication. So that would be an off-label use. Now, some off-label uses are well recognized in the literature. So there is a compendia. There are actually 2 compendia. These are just books that list all the acceptable uses of a compound. And then there are also some new uses for compounds that have not yet made it to be FDA approved, and that would still be an off-label. So on-label means it's in the package insert, it's been submitted to the FDA, it's been approved as safe and effective for that indication. And by safe, I mean that the benefits of the drug outweighs the risk. Off-label means that there could have been multiple studies that have proven that this drug works, but no one pharmaceutical manufacturer has submitted it to the FDA for an official designation. And then the other thing you need to be aware of, if you are on Medicare in the United States, because I see we have some multinational folks on our call today. If you're in the United States and you're covered by Medicare, Medicare Part D plans only pay for drugs that are used for an on-label or off-label but compendia approved indication. So sometimes if you're trying to use a drug and your physician is confident that that drug has evidence either through clinical trials or chemical makeup that would indicate the drug could be valuable in your rare condition, then Medicare Part D's may push back and not want to pay for the drug because it's not compendia or FDA approved. That should not be a game changer yet either, because your physician can write for a letter of medical necessity, and there's a process that we could talk about on a completely other call for how to get your health plan to cover your medication, even when it is an unusual product used for a rare condition.
Absolutely great. Thank you so much. That's great. So we kind of all have the base terms now. So we're going to dive in. And again, don't worry about like trying to track all of this. We will send it to you. There's a lot of information, and it might go a little bit quickly, but let's dive in. So we're going to start with one that many of us know, Rituxan, Ruxience. I'm going to hand this over to you, Dana, and then you just tell me when you want me to move the slides.
Absolutely. So you're going to see on all of these slides that the indication of the drug is always going to be on the right-hand side. And then you'll see in the box that we have the class name, the name of the drug, the purpose of the drug, so what the drug actually does. And for some of you, if you're on multiple DMARD agents, which is a disease-modifying agent, if you're on multiple immunosuppressants, you will see that they work slightly differently. And that's why you might be on 2 immunosuppressants or 3 DMARDs, because they all work slightly differently. And then the common side effects. So I want you to pay attention. I know this is going to go fast, but look at the common side effects. And you will see a few things. You will see nausea, vomiting, and diarrhea. In fact, I've abbreviated it NVD, nausea, vomiting, diarrhea. I think every drug made since the start of humankind has had an adverse effect of nausea, vomiting, diarrhea in somebody. So you'll always see that. But also look at how all of these drugs can increase the risk for an infection, because they are affecting your immune system. That's how they're working in your rare disease. They're tamping down one part of the immune system. And if you take several DMARDs or several immune suppressing agents, that increases your risk for developing an infection. You'll also see fatigue. And I saw someone ask, how can we manage fatigue? Well, you'll see fatigue, low blood cell counts, fever, headache, malaise on almost every one of these drugs. So if you are feeling fatigue, if you are feeling blah, it's the medications. And sometimes it's helpful just to know that the drug is causing it, that it's not you, that it's not that you're supposed to be able to get on top of this and mentally get beyond it. These drugs are pretty tough to manage. So you'll notice these common side effects occurring throughout all of these different drugs. And then some of them are specific. So I want to draw your attention to some of them. They're much more rare, but PML, progressive multifocal leukoencephalopathy, and tumor lysis syndrome, which if you don't have tumors is not an issue, but tumor lysis syndrome can cause a rapid lysis or killing of the tumor cell. And when the cell components get released, it can cause kidney damage. So when you see some of these are much more rare, but I just want you to be aware of them. And that's usually in the box warning of the drug to be aware of too. But let's get back. So kind of, you know how all the slides are going to be laid out now. Rituxan is one of the few drugs that is on label for GPA and MPA. It's being used off label for EGPA, but because EGPA is it's sort of like a component of GPA, that you would expect this drug to work on it. So we've also put in blue whether it's on label for GPA and MPA as a primary rare condition that we're talking about, and then off label for other conditions, or whether it's off label for GPA and MPA. This is the only drug that works on B cells, and B cells are one of your immune cells made in bone marrow and in other organ systems, but it is an immune cell like the white blood cells that help fight off infection, but it can, and this is what happens in so many of these types of rare diseases, your body starts to attack itself. So your body now recognizes normal tissue as being a foreign body or a foreign object. And so it starts to attack your own tissues and cells. So this happens to work on B cells. And the B cells have been very effective for, if you deplete the B cells, it's very effective to prevent the damage that is occurring with GPA and MPA. The problem is Rituxan, which is an every once a week drug for a period of time, then once every 2 weeks for 2 administrations, and then you can go to 4 to 6 months between administrations. And I had a lot of conversation with Sarah on this. This is a tough drug to handle. It is an IV infusion, but you get a lot of infusion-related reactions: fever, chills, nausea, headache, dizziness, shortness of breath, fatigue, headache, I already said headache, hypertension. And all of these make you feel rotten for about a week. The good part is once you are on Rituxan and it's got your disease controlled, then you only have to look forward to doing this every 4 to 6 months, and you can live your life the rest of the time. So part of this is preparing for taking your next dose of your infusion. And part of that may require that you manage, as Sarah and I were talking, PTSD about getting your next dose, or you manage depression, because just knowing that you're going to have to go through this again can make you feel depressed. So we're going to get through all the other drugs and then talk about how you can manage all these, what you can do to either lessen the side effects or manage the side effects. So, oh, excuse me, my nose is itchy. Now, these are, understand we have not listed every single drug. So if you're on a drug that we don't cover today, please put that in the chat or send a note, and I'm sure we can fill in that information on another call or get you something individual. I may not have listed every single drug in each class, but we tried to list the most common ones. So these are the disease modifying agent, and we have several different classes. We have immunosuppressants, we have antimetabolites, alkylating agents, and immunomodulators. So azathioprine or Imuran, methotrexate, cyclophosphamide, and leflunomide are 4 of the common drugs that are used in rare disease as a disease modifying agent. And they all have a purpose of addressing one of your immune cells that might be attacking your body. So azathioprine inhibits T cell lymphocytes. Methotrexate, it inhibits lymphocyte proliferation. Cyclophosphamide alkylates and cross-links DNA. And the leflunomide, it inhibits pyrimidine synthesis. Now, those are all chemical words. But you might be on a couple of these drugs along with Rituxan. And this would be the reason why. If your rare disease is such that it did not respond to just Rituxan, which is the FDA-approved agent for treating GPA and MPA, then your physician is likely, your rheumatologist is likely to start adding in one or more of these, because besides modifying the B cells, they're going to address T cells, or they're going to address lymphocytes, or they're going to address DNA and thereby change the way the body perceives your tissues as being foreign. So all of those are different drugs. They all are disease modifying agents, but they work on completely different areas of your immune system. Now you'll see NVD happens on every drug. Fatigue, anorexia. Anorexia, of course, is not having an appetite, usually accompanied by muscle wasting and weight loss. You'll also see alopecia, which occurs in many of these immunosuppressants. Alopecia is thinning of hair or developing bald spots. Now, usually, if the alopecia occurs, and you'll see alopecia is in azathioprine, it is in leflunomide. I would have to read through this again. I put this together on Tuesday night, and there's a lot to look at. So you don't have to remember everything, just be aware.
Whoops, was I supposed to go back?
No,
Sorry.
you can go,
Okay.
you can go ahead
I'm kind of
because these are,
listening and like trying to get your vibe.
we will go forward and then maybe go back some
Okay.
as we get to people's questions.
Sounds great.
So then the next class of drugs are called immunosuppressants, and you might realize that the disease modifying agents also suppress the immune system, but they're listed as a disease modifying agent because they can actually change the course of the disease. So it's a disease modifying agent because it can slow the disease progression or maybe stop the disease progression. These immunosuppressants simply suppress the immune system. And you can see that mycophenolate, CellCept, which many of you are on, that decreases B cell and T cell proliferation. So it's still working on B cells and T cells, but it pushes it down. It doesn't stop it. So a disease modifying agent can stop the B cell proliferation, but the immune suppressants just push it down a little bit. They can't make it go away. Then we have Tavneos, avacopan, which actually is on label for GPA and MPA. So this and Rituxan are one of the 2 drugs that are actually FDA approved, found effective, and the benefit outweighs the risk for these 2 drugs. So these have actually gone through the FDA approval process. And avacopan or Tavneos is a complement 5A receptor blocker, and that modulates the immune response as well. And then corticosteroids. These are the cheap drugs. Corticosteroids, prednisone, prednisolone. We have budesonide inhalation, because if you are taking a inhalation, either a handheld inhaler or a nebulized inhalation, most of the time it will also have some steroid in it. The corticosteroids inhibit multiple inflammatory cytokines. If you were not on a corticosteroid before 2020, we all heard about them because that was part of our protocol for managing severe COVID. Because in COVID, you would get a overactivation of cytokines, and cytokines in your body attacks your blood vessels and increases the clotting in your blood, so that you can get an increased amount of microclots that can block your blood vessels and cause organ damage. So I'm trying to say all of this in simplified words. So if I'm stumbling a little bit, help me. I'm just trying to find a way to put this in a very understandable mechanisms. Corticosteroids are often used first for immunosuppression, but they have a completely different type of adverse effect profile than the other immunosuppressants. And that's why I'm going to call them out. Corticosteroids, instead of causing anorexia, they increase appetite, they cause weight gain, fluid retention and swelling, otherwise known as edema. You can get steroid psychosis, where your family thinks you've gone crazy. You can get anxiety, irritability. Some people are depressed. Some people have insomnia. You can get steroid-induced diabetes, or at least your blood glucose gets elevated. You can develop hypertension. You get indigestion. You can it causes an increased risk of stomach ulcerations. Long-term steroid use, which many of you are looking at, long-term steroid use, there's a risk of accelerating the development of osteoporosis, which is where your bones get thin and they're easier to break. You get muscle weakness, thinning of your skin. Many of us already have that. That happens just as we age, and then you add corticosteroids on. And you bump your skin on a wall, and all of a sudden you have a bleeding area. Cataracts and glaucoma. Cushing's syndrome, which is where you get a round face and kind of a dowager's hump. a fatty bit of, I'm sure you can't see this, a bit of fatty tissue develops right here between your neck and your back, and you hump over. That's Cushing syndrome, which is also occurs with adrenal suppression. This is, corticosteroids have their own unique adverse effects. The other drugs we talk about have nausea, vomiting, diarrhea, fatigue, headache, muscle pain, malaise, but corticosteroids are different. So I just want you to be aware. And we're going to have to manage all of these. Now, if you're on a medication that normally would cause anorexia and you get put on prednisone, and that might be beneficial because it increases the appetite and you might be able to counteract whatever anorexia or muscle wasting would be caused by the other medication. If in fact you're taking a medication to address an adverse effect of one of your other medications, that's fine, because it keeps you in equilibrium to the best that we can. But if you make a change in your medications, then you might also need to change one of your other medications. So if you discontinue the drug that's causing anorexia, then if you don't potentially reduce the dose of your corticosteroid, then you may truly start putting on a lot of weight. And this is where you, when you go to your physician, telling them everything that's going on with you, not just answering the questions the physician or their nurse practitioner asks you, but now that you have this list of common adverse effects, it would be ideal if you made a chart of your medications and checked off how they're being used, whether this is a DMARD or a B cell drug like Rituxan or an immune suppressant, so that you know what you're on, and then list any of these common side effects that you may be having. Most of these side effects do not require you to stop treatment, but you might want to introduce a drug to manage your hypertension, or you may want to introduce a drug to manage your depression. So the first 3 slides were the drugs that are commonly used to treat the rare disease. And these next few slides are drugs that are often used to manage an adverse effect. So the 2 types of antihypertensives we see most often incorporated into the drug regimen of someone with a rare disease is either an ACE inhibitor or an angio-2 receptor blocker, an ARB. You'll hear ACE inhibitor, which stands for angiotensin enzyme inhibitor, angiotensin converting enzyme inhibitor, but everybody just calls them an ACE inhibitor, or an ARB, which is an angiotensin 2 receptor blocker. You would not be on both of these together. It would be one or the other. If this does not control your blood pressure, there are other antihypertensives we would add. But in general, if your hypertension is because of an adverse effect of one of your rare disease medications, one of these drugs, either an ACE or an ARB, should manage you fine. These are very well tolerated drugs. The one that I will draw attention to is ACE inhibitors. So these are the cheapest. Lisinopril is the most common. And the only thing I want to draw attention to is that some people develop a dry cough on ACE inhibitors. It's an unproductive cough, but it's a dry cough and it's constant. And no cough medicine, no anti-allergy pills, nothing makes that cough go away. If you or someone you know is on an ACE inhibitor and they have started coughing that's just constant, then let the physician know, because you can switch from an ACE inhibitor to an ARB and the cough does go away. Cough will go away. ACE inhibitors and ARBs can cause dizziness. They can also cause high serum potassium levels. So if you have a rare disease and you're being well managed by your rheumatologist, you should be getting lab work done at a minimum once a quarter. So you may only go to get a Rituxan IV every 6 months, but you should be going to your physician once a quarter so that they can be monitoring for changes in electrolytes, which is sodium, potassium, chloride, and magnesium. And these are electrolytes that are present in all tissues in our bodies, and they're necessary for life. And if they get out of whack, then we need to address that rapidly, because if they get seriously out of whack, that can cause death. So you need to be monitoring your lab work. And besides electrolytes, you should be looking at a complete blood count, because you'll notice, let's go back a few slides if we can.
Okay, now I have to figure out how to do this. Let me see.
If you,
I
if you
think I
click
can
the back
go
arrow all
here.
the way there, yeah.
Okay,
So let's go back to Rituxan. Back to
okay.
first. All right. So we don't see, well, we see low white blood cells. And when white blood cells are decreased, there's an increased risk of infection. So if you are traveling on public transportation, you're one of those people that should be wearing an N95 mask, because you really cannot put yourself at risk for having exposure to a significant infection, because your body will not be able to fight it. You're depleting your B cells by taking Rituxan, and that's also lowering leukocytes, neutrophils that are normal blood cells that are fighting infection. Let's go forward. I'm really putting Sarah.
No, this is great. This is great, because this is about, what I love about this is it is about the interaction, and we do take so many of these medications that understanding how one, matches up or doesn't match up with another is really, I think,
Yes.
really helpful.
So if you go, well, let's go back
Okay.
to the DMARDs, right? Too
Yep.
early,
Oh, let's see.
the DMARDs. There we
Okay.
go. If you glance, you will see every one of these drugs causes leukopenia, anemia, thrombocytopenia, low blood cell counts. And we also saw that with Rituxan. Now, if you have anemia, which is low red blood cells, then you're going to feel tired, because red blood cells are what transports oxygen to your tissues. And if you're not making enough red blood cells, it doesn't matter how much oxygen you may be on, you can't transport enough oxygen to your tissues. So you will get muscle cramps, you will feel tired, you will be fatigued. If you have leukopenia, then you have low white blood cells and you cannot fight off infections very well. And if you have thrombocytopenia, then you have low platelets. And platelets are the component of blood that if you cut yourself or you get a bruise, the platelets are what go and stitch themselves over the area of injury to stop the bleeding. So if you're on a drug that can cause thrombocytopenia, you're going to be bruising more often. And if that happens to worsen, then you need to let your physician know, because that could be a sign that you're at too much of a risk for internal bleeding because of the thrombocytopenia. Now, the physician can track this, which is why you should be doing, at least, in my opinion, quarterly lab work to validate what your complete blood cell counts are, as well as your electrolytes. And then when they're looking at the labs, they'll also be checking your liver and your kidney function. So there are enzymes that they check. If they're elevated, it could indicate that there's some toxicity to the liver. And you can see all of these drugs also cause liver toxicity. Some of them also cause kidney toxicity. So they will be doing creatinine and BUN that can alert them. If they start to see these numbers increasing, then they can make adjustments. But that is the type of, but even though you're not able to do labs on yourself, in between every 3 months, or you may be going for labs every 1 month, especially in the beginning of treatment where they're adding these drugs. So just be aware. If you start losing your hair, if you have lost more than 5 pounds, if you have gained more than 5 pounds in the past month, if you have increased bruising or increased bleeding, if you have started to get more infections, even if they were mild infections, that's the type of thing that you need to notify the physician about. And if it were me, and if I had a rare disease, I would be on a text or phone call basis with my rheumatologist, so that when these things happened, I could let him or her know, and then he or she could make a determination if they wanted to. They say, that's to be expected, I'm not worried about it, keep going. That will give you some mental relief. Or they say, I need you to come in and let's do some lab work. Or they may say, let's back off of the drug that we just recently added. But your physician cannot make those choices without your information. All right, let's keep going.
Okay, sounds good. And I'm thinking that we'll fly through the next few, so we leave. like 10
Right, there's
minutes for
only a couple,
questions.
so
Yep, perfect. Okay, there we go.
if you have bronchoconstriction, if you're finding that with your rare disease or some of these other medications that cause shortness of breath, you may be on an inhaler. And most of the time, your inhaler will be a beta agonist, which relaxes the smooth muscles in your bronchioles so they will dilate. And then they'll also have a steroid component. And this steroid that's in this inhaler, you don't really absorb it in the body, so it doesn't cause all of the adverse effects that I went over when I talked about corticosteroids and prednisone. But one of the ways to prevent from getting irritation from using your bronchodilators is after you've used the inhaler or nebulizer, then rinse your mouth and spit. So after you've taken your inhaler, and the way you're supposed to use an inhaler is if it's a dry powder, you breathe slow and deep, and then hold your breath for a count of 10. If it is a mist inhaler, then like these short-acting beta agonists or mist inhalers, you breathe quick and deep, and then hold your breath for a count of 10. And then after you've let your breath out, then you take a sip of water, rinse your mouth, and spit it out. And that can help avoid almost all of the adverse effects. The short-acting agents can cause a little bit of jitteriness. The long-acting agents do not. So if you're using an inhaler regularly, you should be on a long-acting agent. And just keep that rescue puffer in your pocket in case you need it, just rarely. Then we put in a couple of antidepressants because honestly, just knowing you have a diagnosis of a rare disease can be depressing. And it may be valuable to be on an antidepressant for 6 months, or maybe a year, or maybe you'll need to be on an antidepressant for the rest of your life. But most people will start with an SSRI, and we've listed them there, or an SNRI. SSRI, selective serotonin reuptake inhibitor. SNRI inhibits the reuptake of serotonin and norepinephrine. So if you've tried an SSRI like Lexapro or Celexa, and it didn't work for you, the next thing would be to try a serotonin norepinephrine reuptake inhibitor. And these also have some benefit for neuropathic pain. So if you look through the common side effects, some of the drugs do cause neuropathic pain, burning, tingling, stinging, feeling in your periphery. And the SNRIs like Effexor, Cymbalta, Pristiq, those are very common ones. They can treat the depression and also help with that neuropathic pain. Now, sulfonamide is a common antibiotic that you may be put on. You should not be on the antibiotic full time, but you may be on it on a fairly regular basis, it seems like it, because it's used to treat an infection or to prevent an infection if you're traveling on a vacation and you want to be proactive. And let's see what the last slide is. Okay, so electrolyte replacement. I know that sodium, potassium, and chloride are the three common electrolytes that get out of whack, and they can particularly get out of whack if you are not maintaining a good diet and a good hydration. But magnesium is another product that we take it over the counter to help increase our magnesium levels in our body. Depending on the magnesium product that you buy, some of them, like magnesium citrate and magnesium oxide, they cause a lot of diarrhea. In fact, they're primarily used as a laxative. Magnesium glycinate is probably the best absorbable type of magnesium if you need to increase the magnesium in your bloodstream and don't want to risk having diarrhea. But we also use magnesium if you are in the hospital as an infusion. It's part of life-saving, if somebody's having a heart attack, we'll oftentimes give them magnesium because it helps, it helps muscles contract. And then vitamin D. Many of you will be on vitamin D, and that is primarily not necessarily saying you don't have enough sunshine in your life, but all the drugs I've mentioned up until the last few can increase photosensitivity, which means that a little bit of time in the sun, you can get a sunburn. In fact, hopefully the pharmacist and your rheumatologist have suggested that you need to stay out of the sun now that you are treating your rare disease. And you may not be absorbing enough calcium because you do not get enough vitamin D. So most of us are going to be on vitamin D replacement. Most of us over 55 in North America, or in the Northern Hemisphere, to my friend over from England, we need to take vitamin D in order to get enough to let it have its beneficial effect on the bones. So I know, Sarah, when you bring me on, I just have so much to say about these
There's
drugs.
so much we could have done, and I kind of we almost need to do this in two parts because there's so much to talk about. And, I was looking also at the number of medications, and there's a ton of them. So we're, some of us are on 18, 26, so
Yes.
I just think this is so important. So thank you for that. And I know John has been tracking the questions.
Yeah, let's answer.
Yeah, John, do you want to ask the questions? And I'm going to mute myself.
Sure. Sounds good. Well, I'll kind of categorize, so I'll probably not ask every single question, but put them into categories. One of them was Rituxan itself in terms of the dosage and for how long you take the medication. You touched on the side effects. I think we're clear on that, but perhaps you could talk a little bit about the longitudinal long-term use of the drug.
So when you're treating a rare disease, I don't think that that anyone has determined that you only have to use Rituxan for 3 years or 5 years. It is thought to be a lifelong treatment, but in the beginning, and this is usually for the first 1 to 2 months, you'll take Rituxan on a weekly basis. And then once you've achieved a status of control of your rare disease, and some of you may respond sooner than others, but usually by 2 months, then they will give you another dose in 2 weeks, followed by one more dose 2 weeks later. And so we're talking at this point 2 to 3 months of frequent weekly or every other week Rituxan. Then you will go. Now the package insert says to a once every 6 month infusion of Rituxan. So at that point, you get your life back, and you will just have to have a Rituxan infusion once every 6 weeks. Now, that will be dependent on your individual rare disease. So if you do need a drug that depletes B cells in your body, then you may have to take it every 4 months. or you may be able to go 7 or 8 months. So it will be very much patient dependent at that point. But I don't think anyone has said there's a point at which you never have to take it again.
Thank you, Dana. Another around Rituxan itself is looking at the the use of Rituxan along with the Vacapan and how the two relate to each other, and being on Rituxan for every 6 months.
And the Avacopan is a daily drug. So
So the question, yeah,
so that's an example where they work on two completely different aspects of the disease. So Avacopan is a complement 5A inhibitor, and that's just a different approach to reduce your body's immune response to its own tissue. So we're talking about rare disease, but another disease that uses a lot of these drugs is rheumatoid arthritis, and psoriasis uses a lot of these drugs. And those are conditions, they're not so rare, but they are also conditions where your body starts to attack your own cells, depending on the part of the body that's affected by it. And that's what we're trying to do. And it turns out that with Avacopan, it's actually pretty well tolerated. And it is by inhibiting the complement 5 pathway of the immune system, it can, in combination with Rituxan, maintain a pretty good equilibrium and reduce the disease process.
Oh, you're muted, John.
apologies. Another set of questions talk about or ask about prednisone and its side effects. Bone density, I think you talked about that, osteoporosis, the corticosteroids in terms of long-term use, what a person has to be prepared for and how to work with that.
All right. So there are some things I wanted to bring this up. And there were a couple of people asking about how you manage these adverse effects. So number one, most of the medications you take orally will be better tolerated if you take them after you've eaten a meal. And that's true for prednisone as well, because it causes a lot of direct irritation to the GI system, as do some of these other drugs. So if you take them with food, you just want to always take them the same way. So if you take them with food, even if food impacts the absorption, if you can adjust your dose to be the right dose for you when you take it after breakfast, after lunch, after dinner, rather than taking it on an empty stomach. The other thing with all of these drugs is to stay well hydrated, and not just with water, but with electrolytes in your water. So if you like to drink a electrolyte water like Gatorade, I live in Florida and I hate Gatorade. It's like the worst tasting thing to me. But there are so many different fluids you can buy that just are not just water. They also have some electrolytes in them. And that's the best way to stay hydrated. So drink that, or make iced tea, or you know, whatever you like to drink. Just make sure that it has a little bit of electrolytes in it, and that way you can reduce some of that feeling of fatigue. You can reduce some of the feeling of just malaise when you're better hydrated.
Real quickly, a couple of questions about supplements relative to vasculitis, like you talked about vitamin D, and its relationship with drugs like Avacopan and others, and how effective it is, and what other things you would consider as appropriate supplements, either for the medications or for the illness itself.
So the first place I would start is looking at your lab work. If I were involved in your personal care, I would want to look at your lab work and see whether or not you needed, what you needed supplement on. So we know vitamin D is important to overcome the prednisone effect of osteoporosis. And we also are going to have to give it to you because you're not supposed to get in the sun because of photosensitivity. Then what's your calcium level? Now, serum calcium level isn't the best measure because your body will take calcium out of your bones to keep your serum levels normal, but we may need to supplement calcium. And if we do calcium, we need to do calcium and K2 because that will help the calcium go into your tissues and into your bones to be effective. So calcium and K2, vitamin D, it may be beneficial to supplement some of your other vitamins. The B vitamins can oftentimes get deficient. I prefer a vitamin from a specialized manufacturer versus buying just over-the-counter Nature's Made vitamin or Publix vitamins, and primarily because you don't always absorb them well. So vitamins that are in capsule forms are better absorbed than vitamins that are in tablet forms. But it really is going to depend on your lifestyle, what your lab work say. And I don't think you could just automatically say you need to take a vitamin. Now, I personally take a multivitamin because I have horrible eating habits. And if you find that you also have horrible eating habits, then you may want to take a good multivitamin and then add on the vitamin D. In terms of other supplements, if you're having insomnia, the best treatment for insomnia is cognitive behavioral therapy, which is in clinical trials the most effective, and I've never been able to do it for myself. I can't sit there and tell myself I need to relax and I need to fall asleep. I can't do it. I can turn off all the lights and all I do is sit there and wonder what's going on when I can't see anything because the lights are off. You know, my brain just goes haywire. So there are other things you can take. You can take, for some people, you can have melatonin. For some people, if you have access to THC in a legal mechanism, sometimes that can provide relaxation. But the most important thing is that if you're considering adding anything over the counter to your treatment regimen, you need to speak with your pharmacist and your rheumatologist and check it out for each of the products you're taking. So we know vitamin D is very common. But yeah, other than that, check it out. Don't just go to the store and say, that's a pretty bottle. I think that's going to do it for me, and take it, because you need everybody to be aware of what's going on.
That's great, Dana. And if you just have one more question in a few minutes, you could respond to, and one that's kind of important to us for on Rituxan. I'm on Rituxan, and it's vaccine coordination. You know, how do we get the vaccine? When do we get it? How is it effective? You know, effective is with the immunosuppressant drugs.
So, in general, immunosuppressant drugs suppress the response to a vaccine. But at least in the United States, the recommendation is that you should still be vaccinated because the immunosuppressant drugs are going to reduce your normal response to being exposed to an infectious condition. So it is best if you coordinate, for instance, flu vaccine, COVID vaccine, things that you're going to get on a yearly basis, and you coordinate to get them, in my opinion, in the middle of a Rituxan cycle. So if you do Rituxan, and God forbid you don't do it in December, because that would like ruin your Christmas. But if you're doing March and October for your Rituxan, then get the flu vaccine in August and get your COVID vaccine in August. Normally, I recommend to people that are not immune suppressed that they get their flu vaccine in October, because most flu is most active in in the Northern Hemisphere in the months of January and February. So you want it on board, but you still want your titers high in January, February, and March so that it doesn't start to drop. And the same would be for COVID. If you are someone who wants to get a COVID vaccine, I don't think there's any issue with getting them both at the same time with your immune suppression, but it's best if you are on an infusion drug, if you can do the vaccine in between the infusion as far apart as you can, if that makes any sense.
That's super helpful because it is complicated, as we try to think through this. And yeah, I'm with you, John. I always say I have the immune system of an infant who might actually have a stronger immune system.
Yeah. Have you been eating dirt? That's how we get immune buildup in an infant.
There you that's
Crawling
funny.
around on the floor and licking their hands and all
Right.
that stuff we don't like them to do, but that's how we could build a good immune system.
Right. And then for us, they just want to just kill it. So
Exactly.
this, I know we went a little bit late, but this was phenomenal. Thank you so much. I think, and John, thank you for kind of tracking all those questions and synthesizing them for us. It is complex, the medications that we're on. And it is both maddening and also the greatest gift that we have. Because again, many of us wouldn't be alive today if we didn't have the medications we're on. But since it's a rare disease, we always say our Rituxan is Pam and I always say it's like an atomic bomb because it's not selectively treating anything. It's just blowing up your immune system, and you can feel that. So this is really helpful. For me, it's helpful to have information. Every little bit of confidence I can have when I go to a doctor, that helps me feel like, oh, I know what you're talking about, or I get to ask you a question that actually I feel like I am your partner as opposed to lesser than, is just, that's power for us. And there's not a lot of power we have with these rare diseases. So thank you for sharing all of that. I'm going to ask if you are willing to turn on your video. We'd love to have as many of you that are willing to turn on your video, because two things we're going to do. One is we are going to do a big wave, which is our big thank you to Dana for taking the time to be with us today, to research all of this, to look at this, pull together that information. And then I'm going to ask you to put your hand up and then bend it and pat yourself on the back.
All of us.
All of us
deserve it
being
because
here
everyone
today.
wants to learn.
Right. And some of the medications that Dana spoke about, specifically prednisone, and the avacopan. There's some other ones that we have that are in our Rare Candor podcast, where we hear from people who've had some of the experience with these medications. So we'll send all this out in a follow-up email to you. It'll have the document with all the information that Dana went through, as well as some links for additional resources. We can't thank you enough for being with us today. We can't thank you enough for being engaged. I can't remind you enough to go into your heat kits, got to put a little plug in and make sure that you've filled out. I mean, this isn't my kit, but there you go. Pam's got it up too. And, my kit is packed full of medications. So go in and do your little heat kit, make sure that it's filled out. It is a lifesaver. When you go to a doctor, you don't have to try to remember all your meds. You literally show it to them. So thank you so much for being with us today. And again, big thanks to Amgen for, creating a medication,
Yes.
avacopan, Tavneos for us.
And I want to say one thing. Somebody made a comment, and I want to just say, if the drug you're on, or if the drug your doctor wants to put you on is not covered by your Part D plan, no is just the first rung on the ladder to yes. So don't accept it. There are letters of medical necessity You can call the plan. You yourself, as a a Medicare beneficiary in the United States, you can request a coverage. And a lot of times your voice will be more powerful than your physician's. So there's a lot of things you can do. I'm happy to help you navigate that process. But yeah, that will be an issue from time to time, and don't let it stop the treatment of your disease.
Thank you, Dana. Thank you for sharing that. You are an inspiration and really appreciate you. Thank you all for being here with us. We have another one in a few weeks, and I'll put that in the email that comes to you too. So thank you, everybody. Really appreciate your time today. Thanks again, Dana.
Bye.
Bye-bye.